Joining us today is Dr. Mary Patterson. Dr. Patterson is the medical director at the Center for Simulation and Research at the Cincinnati Children's Hospital. Thank you so much for joining us today, Dr. Patterson. Today, Dr. Patterson is going to be speaking with us about the simulation research that's done at her institution and what lessons we can learn as they apply to medication safety. So, Dr. Patterson, can you start off by telling us what simulation is and how it is used to study as well as improve patient safety?
We've been doing healthcare simulation for about 8 or 9 years now at Cincinnati Children's, and we have done a lot of work both on teamwork and communication and identification of latent safety hazards in the clinical environment, as well as human factors work around usability testing with respect to the new equipment, new facilities, new teams.
And what are some of the lessons that have been learned from the work that you've done so far?
We've learned a number of things from our use of simulation. I think some of the most important things we've learned have included the ability of us to use simulation to identify latent safety hazards in the environment, to identify gaps in knowledge or skills, both for individuals on the healthcare team as well as for teams and teams functioning as a whole. It's also been an important way to identify systems issues and human factors issues in the clinical environment. And hopefully one of the strengths of simulation is that we can identify these problems hopefully before they touch a patient.
In this podcast series, we're focusing specifically on medication safety in the emergency setting. Are there any lessons that have been learned through simulation specific to medication errors?
I think that medication errors are in some ways probably more common than we believe, and I think that we probably don't actually do a good job of capturing all the medication errors that occur. Oftentimes a medication is drawn up or mislabeled in a simulation, and we see that happen on a recurrent basis. It happens pretty consistently. One of the things that moved us to do within our own institution was to use independent double checks for high-risk medications. You probably know that independent double checks of high-risk medications are required in a routine environment, but not required in an emergency or during a code situation. In reality, given what's going on during a code or during an emergency situation, that's when an independent double check of a high-risk medication is most important, because that's when people are rushing, that's when people tend to make mistakes because there are a lot of things happening at once, and it becomes difficult to focus on for example, the dose of epinephrine or the dose of bicarbonate or other things, and oftentimes the concentration may be missed, the volume may be missed, people may misinterpret milligrams for milliliters, and all sorts of bad things happen.
You've mentioned independent double checks. Are there any other lessons that have been learned through simulation that can help improve safe medication use in emergency situations?
It's really important that people don't rely on their memories. And particularly, again, we're using epinephrine and other high-risk medications. It's really important that there be some sort of a reference that preferably already done by weight, and whether that's a Broslow tape or some other cognitive aid that allows one to look at what the dose is in milligrams, what the volume is, what the concentration is, so that we aren't trying to calculate or rely on our memory. Having a cognitive aid is, rather than relying on one's memory to calculate a dose, is really critical.
And at your institution, what type of debriefing is done with the team after a simulation exercise?
So we use a standardized debriefing template, and that's allowed us to make sure that we cover, because we have a time-limited ability to do the debriefing. The standardized debriefing allows us to cover the important areas, and one of the areas we always cover during our debriefings are any problems with medications, whether that's related to availability, whether that's related to ability to draw it up or find it. We've also found things like, for example, 2 concentrations of glucose stored one next to the other, or 2 concentrations of bicarb stored, which again makes it very easy to pool the wrong thing. So in terms of the human factors side, where are we storing medications that look alike or sound alike but have very different effects? Are we putting, for example, normal saline next to potassium?
You've highlighted the importance of communication as well as teamwork. What are some of the lessons for effective teamwork that have been learned through simulation?
Clearly, one of the key elements, and this applies to medication safety as well as others, is the ability to create an atmosphere where it's psychologically safe to speak up if one is concerned. So the ability to raise concerns, ask clarifying questions, and rather than blindly following. I think that we oftentimes, many of us who've been in healthcare for a long time, have this. Oftentimes we'll get sort of a gut feeling, a nudge, a pinch that there's something not quite right, and the ability to speak up even when one isn't exactly certain what it is that is giving us the uncomfortable feeling, but to speak up when there is that concern rather than blindly following through, I think is key to good teamwork, to really look out for one another in terms of what we're doing, because I may be doing something that you can see is wrong, and you should feel very comfortable to stop me and question me. And that certainly applies to medication safety, that open communication around what are we using, why are we using it, double checking dosing, and prior to administration. These are all key to safe patient care.
And how can we translate some of the lessons that have been learned in this simulation environment into a real world environment and demonstrate that it actually improves patient care as well as patient safety?
So it is interesting. There is pretty good literature that the physiologic responses we create in a simulated setting are actually mimic very closely the physiologic responses of healthcare providers in actual patient care settings. So the key then is, how do we translate, or how do we demonstrate really, that what we do in simulation translates to actual patient care? So there's just starting to be literature that really demonstrates that, and not all of it's in, for example, pediatrics or emergency medicine. There's literature in the surgery, literature around transfer of skills. There is literature around transfer of ACLS skills, central line insertion, OB, difficult deliveries, that demonstrates that what we do in a simulated lab or a simulation lab then does actually impact patient care. There's not as much literature as we'd like, but I think we're developing the evidence base that does demonstrate that.
And do you have any advice that you would like to offer the trainees that are listening to this podcast to improve safe medication use in the emergency setting?
We all tend to believe that if we are careful enough, conscientious enough, and smart enough, we won't cause patient harm. And the bottom line is that all of us are going to make mistakes. It's part of being human, that it's not a question of if we're going to make a mistake, it's a question of when we're going to make mistakes. If I'm working an overnight shift and it's 5 in the morning and that just tends to be a really bad time for me, I always tell our nurses mainly, so it's 5 in the morning, I'm really tired. If you see me doing something stupid, please stop me. Because I'm giving people permission, because I know I'm fallible, I know I'm going to make mistakes, so please don't let me hurt a patient.
Well, thank you so much for joining us today, and thank you to our audience for listening to this episode of iPEMS. To learn more about medication safety in the emergency setting, please tune in to other episodes in the podcast series.